with extensive expertise in community health and occupational health practice in Malaysia. He is currently attached to Britain OcuHealth Service in Johor Bahru and serves as an occupational health physician at Clinic Paragon Labuan, which is wholly owned by the organization. He holds an MBBS degree from Malacca Manipal Medical College and a Master of Community Health Science, Occupational Health from University Kebangsaan Malaysia, UKM. He is a Deutsch registered occupational health doctor, a Petronas, Shell, OGUK, and Malaysian Marine approved medical examiner, and is also certified as a medical review officer (MRO) and assistant medical review officer (MRO) for workplace drug and alcohol program. With over a decade experience in occupational health and consultancy, Dr. Ruben has provided advisory service to major industry including oil and gas, petrochemical manufacturing, offshore sector. His areas of expertise include fitness to work assessment, medical surveillance for chemical and noise exposure, workplace drug and alcohol management programs, occupational odometry, and health risk management. He also has been actively involved in developing occupational health policies, standards, and digital solution for medical surveillance. So Dr. Ruben is a frequent speaker of a national occupational health seminar and webinars, sharing practical insight on fitness to work, medical surveillance, and noise in induced hearing disorder and workplace health management. So without further ado, please join me to welcome Dr. Ruben to proceed with our third session for today. Dr. Ruben? Dr. Ruben?
It's not yet in.
Oh.
We can wait for him first.
Okay, participant kita tunggu for Dr. Ruben. Aisyah,
Yeah.
is Dr. Ruben?
Okay. Baru masuk. All right. Dr. Ruben, are you okay? Okay. You can, you are the host now, Dr. Ruben. Okay, there, yeah, we can see you.
Unmute yourself, yeah, Doctor.
Okay, am I audible?
Yes. Participant, can you give us the feedback if you can see Dr. Ruben? And once Dr. Ruben share his slide, can you check if you can see the slide? Can I see your feedback, participant?
Okay.
Yes, Doctor.
Okay, I'm gonna share my screen. Okay, can we now see the slides?
Participant, can you see the slide? Yeah, they can see the slide, Doctor.
Okay, just 1 second. Wait 1 second, I'll be back shortly. Okay, apologies for the delay. So let me try to share screen again. Okay, can see my slide now?
Participant can give the feedback to Dr. Ruben. Yes, doctor, they can see.
All right, so let me start with the presentation. Thank you for inviting me here today. So my presentation today will be protecting workers against chemicals hazardous to health. Yeah, and the scope of the presentation today will be the principles of MS, principles of MRP, common chemicals for medical surveillance, and the fundamentals and case scenarios. Yeah, each of these scope they actually can be a topic on its own. Yeah. So what I'm gonna do is certain things I will touch it superficially, while certain things we will go more into details. Yeah. Right. So when it comes to medical surveillance, we have to understand that medical surveillance falls under the category of secondary prevention. Yeah, the main focus over the management of chemicals at workplace should be starting from the primary prevention. Yeah, so primary prevention is where the use regulations, governance and enforcement by DOSH, self-regulation by the companies, establishment of those limits, ALARA principles, doing a CHRA, and improving the control measures come into place. Yeah, PPV would be the last to consider. And medical surveillance and medical removal protection will fall under secondary prevention. And the purpose is to reduce the impact of a disease or injury that has already occurred by early detection and treatment. Yeah. while return to work will fall under tertiary prevention. And if return to work is unsuccessful, then the employee may turn out to be a case of going into a medical board out, or accommodation and compensation comes into place. Yeah. So the definition of medical surveillance would be a systematic and periodic assessment of the state of health of workers upon exposure to chemical hazardous to health, which may include biological monitoring and biological effect monitoring. Yeah. So I would always stress on the importance of, before performing the medical surveillance, we need to review the CHRA report and chemical exposure reports first. Yeah. And this is to understand the indication, the exposure, the job activities of the environment, the routes of exposure, the adequacy of control measures, and finally, what are the risks involved to the workers. Yeah. So the indications for medical surveillance would be any occupational exposure to chemical hazardous to health exceeding 50% of the PEL, and or significant skin absorption or evidence of health effects. Meaning to say, this number one criteria, 50% of the PL alone, is not the primary factor. If the assessor is of an opinion during the assessment that there is evidence of health effects or there is a significant risk, in spite of a lower risk, the assessor may still determine that a medical surveillance is still required. And all these are to be documented in the CHRA report. Hence, why it's very important for us to go through the report prior to commencement of the medical surveillance. Yeah. So this is actually from the guidelines to perform an assessment, CHRA assessment, where a risk assessment is done. Yeah. And after which, based on certain parameters, such as if there is a risk which may cause ill effects, or if the chemical listed in Schedule 2, or if there is a risk of systemic effects. Yeah, and after which the assessor will assess what is the level of the risk, moderate to high. Yeah, and the level of risk pretty much depends on the control measures in place as well. Yeah. After which, if the assessor finds that there is a air monitoring more than a 50% TWA of the, or the results of the biological monitoring is more than a biological exposure index, yeah, and then only the medical surveillance will be indicated. Yeah. And as I mentioned earlier, if there are any significant factors other than the 50% PL, the assessor can also determine that a medical surveillance is required. Yeah. So in the conduct of the medical surveillance, three main parties have their duties. Yeah, the OHD, the employer, and the employee. Yeah, the duties of the OHD would include to conduct pre-placement or periodic medical surveillance, to review the CHRA or the CAM reports, to determine the fitness to work, fitness to be exposed to relevant chemicals, including fitness to wear the PPEs, yeah, to analyze and investigate abnormal findings, to obtain medical reports from the employer or employees if needed, yeah, to explain the results of investigations and relevant findings to the employer and employer and the remedial actions, to notify to DOSH or employer on MRP cases or JKKP7 cases, yeah, to submit and present the reports to employer, yeah, and to assist in management of the occupational disease and poisoning, including referral for treatment and rehab whenever required, yeah, to participate in training if required, and to perform exit medical assessments prior to retirement or prior to exit from the work unit. Yeah. The duties of employer would include to appoint an OHD, to ensure proper process of the medical surveillance program is adhered to, and to allow and assist the OHD to visit the workplace to investigate, yeah, to cooperate with the OHD in the management of the employees, to institute MRPs within 1 working day, to allow employees under MRP to be accommodated to other jobs, yeah. They themselves will need to notify certain disease at the workplace to the authorities, to DOSH, to explain the general MS program to the workers, especially training and awareness, yeah, to review the workplace control measures, to ensure record keeping, yeah, while the employee too, they have their own responsibilities, such as to undergo training provided by the employers, to report early signs and symptoms, especially if they suspect that it's due to exposure to chemical hazardous to health, yeah, and to comply to the requirements stipulated under the medical surveillance program, yeah, right? So the components of medical surveillance will include pre-placement and periodic assessments, biological monitoring and biological exposure monitoring, health effects monitoring, notification when required, workplace investigation when required, assist in disability management, return to work assessment, record keeping and monitoring. Yeah. So the process flow of the medical surveillance would actually start from when the employer requests us to conduct a medical surveillance. We will need to review the CHRA report, and I would suggest to request for the chemical exposure monitoring report as well, after which identify which chemicals require medical surveillance, yeah? After which we determine the appropriate method as per the medical surveillance guidelines, and we perform the medical assessment and biological sampling as per the guideline, yeah? The results of the medical surveillance, when it's normal, we send the reports to the employer and employee, yeah? We send the summary of the program for that particular year to DOSH once completion, yeah, and we do record keeping and continue the annual medical surveillance accordingly, yeah. However, if there is an abnormal finding, we need to inform and provide recommendations to employee and employer, yeah, and implement medical removal protection when required. We will need to notify DOSH as well and do a record keeping, yeah. And for these abnormal cases, we will need to eventually perform return to work assessments, yeah. So the types of medical surveillance would be pre-placement, periodic, return to work, and the latest one would be the exit medical examination, yeah, the latest requirement. So pre-placement is to establish a baseline data at a new workplace or new work unit, or if there is a new chemical hazardous to health introduced at the work unit, yeah. It has to be conducted within 3 months of the clauses above, and during which we look at the findings and we decide if the worker is fit or not fit, yeah. Of course, the word used in the documents would be fitness to work. However, this is essentially, basically, these are fitness to be exposed to the chemical hazardous to health, yeah. So, not to be confused with fitness to work in general. This is because a worker in any company might be doing a multitask work where only partial part of the work is exposed to chemical hazardous to health, yeah. So if there is any need to do a medical removal protection, that doesn't mean the worker cannot go to work at all. It just means that the worker cannot perform the work that is exposing the worker to chemical hazardous to health. Yeah, whichever other works, when feasible, existing work which are safe to be done, they can do that part of the work without getting exposed to chemical hazardous to work. Yeah. Periodic assessment is the monitoring for the purpose of identifying changes, most often than not, in comparison to the baseline findings. Yeah, it is sorry, there's an error here. Not benzene alone, to chemical hazardous to health. Yeah, it is done annually, and for heavy exposures, the OHD may recommend to conduct it 3 to 6 monthly. Yeah. A return to work assessment is conducted before the end of MRP. Yeah. Typically, most chemicals which are found to be abnormal in their biological monitoring, they can subside within 1 month. So you can recommend to repeat the assessment to do a return to work within 1 month. Yeah. However, we need to also take into consideration, is 1 month enough to rectify control measures in the workplace? Yeah. So there are times where 1 month may not be adequate. We may need to recommend the return to work assessment perhaps after 3 months. Yeah. And instead of 1 month, which might be such a short notice to get things done. Yeah. So exit medical examination is done when the worker is exiting the work unit or no longer exposed to the chemical hazardous to health. Yeah. So how do we conduct the medical surveillance? Yeah, it always starts from history, and in an occupational health setting, the history includes medical family history, occupational history, including exposure history, training history, and awareness towards the chemicals which they are exposed to. Yeah. Then we conduct a symptoms survey to determine if there's any health effects present. Physical assessment is also to determine if there's any health effects present. We need to do relevant clinical tests to determine if there's any target organ dysfunction. Yeah. We need to do assessment to wear respirators where applicable. Yeah. We need to do biological monitoring if the technique is available for that particular chemical. Biological effect monitoring, we need to analyze, interpret, recommend, and certify accordingly. Yeah. We need to issue MRP if required, notify if required, after which submit a summary. Yeah. So coming to health effects monitoring for MS, this is a process to monitor clinical onset of diseases following an exposure to chemical hazardous to health, where it measures early reversible biological changes in an organ or system to detect potential harm from exposure to workplace hazards. Yeah. Health effects monitoring is important because it is the only parameter to monitor health outcome following exposure to chemical hazardous to health without biomarkers. Or it is able to show the extent of health insults due to the chemical hazardous to health. Yeah. And it can identify health insults that may follow an acute high dose exposure to chemical hazardous to health. Yeah. So depending on which chemical that is identified, we will then focus on certain target organs. For example, if benzene comes into question, we'll be focusing more on hematopoietic system. Yeah. While if xylene comes into question, we'll be focusing more on kidneys and the liver and so on. Yeah. So the target organs monitoring, of course, there is a general assessment to be done, but on top of that, we need to be aware through each routes of exposure: inhalation, skin absorption, ingestion. Yeah, which are the target organs which are possibly going to be affected through these three routes of exposure, and plan our assessment accordingly. Yeah. So biological monitoring is the measurement and assessment of agents and all their metabolites in their bodily tissues to evaluate the exposure and health risks in comparison to an appropriate reference. Whereas biological exposure monitoring is the measurement and assessment of subclinical biological effect caused by the hazards. Yeah. It measures biochemical responses that may have health consequences for the individual and may be caused by factors other than occupational exposure. Yeah. The importance of both are to check what control measures are working, to check what work practices are protective, to check if the training is understood and followed, to determine if there is any excessive absorption, and to decide on medical removal protection. Yeah. So, personal exposure monitoring is basically to monitor the personal exposure level. Yeah. Whereas biological monitoring is to monitor the dose in the body through the biomarker of exposure. Biological effect monitoring is to monitor biomarkers of early biological effect, while health effect monitoring is to monitor the clinical onset of disease. Yeah. So for example, we have here xylene. Yeah. The health effect monitoring would be through the history and examination. Through history and examination, we try to determine if there are any health effects. And typically in xylene, if there are any health effects, it may include damages to surfaces of eyes, intestinal tract disturbances, liver damage, central nervous system symptoms, kidney damage, or skin problems. Yeah. The biological monitor for xylene would be urine methylhippuric acid, while the biological effect monitoring for xylene would be kidney function tests, urine analysis, liver function tests. These are done annually, while full blood count as a baseline. Yeah. Okay. So the frequency of medical surveillance should be at an interval of not more than 12 months. Yeah. More frequent medical surveillance is recommended if there is a case of MRP or if there is a concern on work-related health effects. Yeah. And based on the severity of the exposure, at times 3 to 6 monthly medical surveillance would be recommended. Yeah. So when it comes to performing workplace investigation, we need to understand who are exposed, how the incident happened, what are the work activities, review existing control measures, what are the lessons learned, communication with the employer-employee, and arriving to a conclusion. There's a need to implement control measures and to re-evaluate them. Yeah. So whenever any incident happens, the primary aim is not to find fault. It is mainly for the purpose of rectification of an existing problem. If it's related to workplace, it can be a substandard condition or a substandard practice. And that's what we want to essentially rectify. Yeah. And there is a need to, after implementing improvement in the control measures, there is a need to re-evaluate it periodically as well. Yeah. And I have to remark here that investigations are conducted by a team of professionals and not the OHD alone. Yeah. And the investigation is not for a single individual, rather it's for the entire work unit. Yeah. Right. So we would be required to notify to DOSH on all definite or suspected cases, or Sometimes the biological monitoring could be normal. However, health effects are present, and these health effects are suspected related to work. Yeah. Of course, the most direct way to notify is whenever there is the biological monitoring result exceeding the DL. Yeah. We may also need to assist on disability assessment whenever required in terms of how the illness or disability affects daily life and work life to determine whether this is a temporary or permanent disability and what are the further recommendations here. If some of us recall, whenever we are submitting a JKKP7 through my KKP system, one of the things that we need to click is there hilang upaya kekal atau tidak? Yeah. So it is essentially one of our duty as well. Yeah. So when it comes to record keeping, yeah, generally it's understood that the magic number is 30 years. Based on the guideline, the OHD has a responsibility to maintain records for 7 years, while the employer has a responsibility to maintain records for 30 years. Yeah. However, I would highly recommend all OHDs to maintain the records as long as possible in a secure archive, in a soft copy manner. Yeah, hard copies will eventually be destroyed as ages pass. Yeah, keep in a secure archive, and we will never know when we will need it someday. Yeah, right. And this record keeping is also essential to monitor serial changes from baseline up to the annual test. It's useful for any comparison or investigations when the time comes. Yeah. Okay. So a medical removal protection, it means a temporary or permanent removal of the affected employee or a worker from a work area in order to prevent from further exposure to chemicals hazardous to health. Under the MRP, the worker could be removed temporarily or permanently to avoid further exposure to the chemical hazardous to health. Yeah. So the primary aim is we suspect this chemical can potentially cause harm or is already causing a harm. Hence, we want to remove the worker away from the chemical hazardous to health. Yeah. MRP is to be initiated within 1 working day upon notification to the employer. Yeah. So let's say you receive the test results today, yeah, and you issue the MRP using a USH51 form today, yeah, and subsequently you're also notifying to DOSH via JKKP7, yeah. So upon receiving the USH51 document, the employer has a responsibility to remove the worker from the exposure to the chemical hazardous to health, which is identified within 1 working day. Yeah, and usually when a case of MRP comes into picture, DOSH would move very quickly as well to visit the workplace. Yeah. So MRP is the decision to MRP is based on one of the following. Yeah, the clinical findings, target organ abnormality, the BM or BM exceeding the limits, or if it's a pregnant employee or breastfeeding employee, or if there is a situation where the further exposure to the chemical may worsen a non-chemical work-related condition. Yeah. For example, exposure to arsenic may aggravate chronic renal disease. Yeah. So the worker has a chronic renal disease which is not related to the work. However, hereafter, exposing the worker to arsenic may aggravate the chronic renal disease. Hence, there is a need to remove the worker from the exposure to this particular chemical. Yeah. or if there is a medical condition that may affect the accuracy of biological monitoring and biological exposure monitoring results. Yeah, this is again one of the common medical condition would be, of course, kidney disorders. Yeah, because to obtain an accurate BM or BM result, we need creatinine corrected results. And if a person has a kidney disorder, we are almost invariably going to get abnormal urine creatinine findings. Yeah, hence the BM or BM is not going to be accurate. Yeah. Okay. So the duration of initial MRP is until the date of next return to work assessment. Further duration of MRP will be decided during the return to work assessment. Yeah. And if the OHD decide to extend the MRP for some reason, DOSH need to be notified again. Yeah. For example, in the case of lead exposure, duration of MRP is 1 month. Yeah. Because this is the duration that we anticipate significant reduction in the concentration of blood lead. Yeah. When the employee is fit to return to work, the employer should be notified again. Yeah. And this is using the medical surveillance forms. Yeah. Appendix 6 MS recommended forms are essentially the normal use forms that we use to conduct the medical surveillance. Yeah. Most importantly, this pointer here, to prevent recurrence, the duration of MRP is also subject to improvement of the workplace conditions, which cause the removal in the workplace. Yeah. So let's say you are performing the MRP within a month and the levels of lead have significantly reduced. However, you find that the adequacy of control is still not up to the mark. Yeah. So you have within your rights to extend the MRP, because if now the worker goes back to the same workplace without any improvement in substandard condition or substandard practice, the blood lead is going to increase again. Yeah. And if left exposed for a long time without a proper control measure, it can then lead to health effects. Yeah. Okay, coming to permanent removal. Yeah. Permanent removal is recommended when there is a permanent medical condition due to the exposure to chemical hazardous to health, which obviously will worsen the condition when further exposed. Yeah. The permanent medical conditions which are not related to the exposures, or a second scenario is there is a permanent medical condition which is not exposed to chemical hazardous to health, but the condition reduce the degree of tolerance to health effects of chemical hazardous to health. For example, in significant renal impairment, we require disposal of the chemicals from the body, and this requires healthy kidney. Yeah. But when there is kidney impairment, the chemicals cannot be excreted as usual. Yeah. It may accumulate in the body. Yeah. Or another example would be an employee with history of myelodysplastic syndrome, and persons diagnosed with liver disease are unfit for exposure to benzene, because we all know that benzene metabolism mainly happens in the liver. Yeah. Right. An employee may return to work when free from medical conditions that can be worsened by exposure to the chemicals, the signs and symptoms have subsided, the BEI has normalized, adequate control measures have been implemented to prevent recurrence. Yeah. While for pregnant and lactating mothers, the decision for return to work should be made on case-to-case basis. Yeah. So here's just a flow from the guidelines. Yeah. So if there is an abnormal medical surveillance finding, we impose a temporary MRP. If the worker is fit, then we have to decide if the MRP is permanent or not. If it's not, the employee may return to work. Yeah. For some reason, if the MRP is permanent because the worker is not fit, that may lead to a permanent MRP. Yeah. Okay, so the next few slides, I'm just gonna go through very, very quickly. Yeah. So this is the form which came into effect, employee referral form, where companies will have to provide to the OHD prior to commencement of the medical surveillance, yeah, as a form of official referral, yeah. While these are the medical surveillance recommended forms, which we will find from the medical surveillance guidelines alone, yeah. We can either, based on this template, create our own forms without deviating from the template, or we can use back the same pages. No problems. Yeah. As I informed earlier, we are going to document the medical history, the family history, occupational history, exposure history, occupational history, and the history of training, all within these forms, followed by history of health effects, and the current clinical findings. Yeah, we will be documenting the findings from physical examinations. Yeah, and we also need to comment if these findings are due to, if there are abnormal findings, these findings are due to exposure to the chemical hazards to health or not. Yeah. So these are examples of biological monitor and biological effect monitors. So if the results are normal, fine, everything is great. Yeah. If the results are abnormal, we need to provide our remark. Yeah. And here's the column to assess if the worker is fit to wear respirator or not. If there are any findings which are significant, we need to comment if it is work related or not. Yeah. And finally, to recommend when is the next assessment. Yeah. Here is a place to document MRP, followed by use 51 form. Yeah. Here's a summary of records for the employee, and this is one of the summary which routinely we have to provide to the employee. Yeah. This would be certificate of fitness, and as I mentioned previous, not to be confused, it is not essentially a certificate to fit to work. It's essentially certificate of fitness to be exposed to that particular chemical. Yeah, and we need to decide fit or not fit to be exposed to the chemical, and we need to issue one cert for each chemical. Yeah. So here's the use for form, a summary report for medical surveillance. And in case individual worker needs to be removed from work, we need to fill this up, use 51 form, and submit to the employer and DOSH. Yeah. And this is a second form for the MRP or abnormal findings, use 52. Yeah. So this would be a summary of all the workers in the work unit who has abnormal examination findings, whether this is related to chemical exposure to health or not, and what were the conclusion and recommendations. Yeah. While this is an example of notification to DOSH, online notification via the MyKKAP system. Yeah. All right. So Those would be the basis in regards to the forms. So now let's go to the next scope, which is chemicals for medical surveillance and some fundamentals. Yeah, this is a part which I'm going to be a bit superficial. Then we go and discuss on case scenarios. Yeah. So chemical hazardous to health means any chemicals or preparations which are either listed in the schedules in USH 2000, are classified in any hazard class specified under health hazards of first schedule of the OSH classification of classification, labeling and safety data sheet of hazardous chemical, class 2013, or it comes within definition of pesticides under Pesticides Act. Yeah, this is very important. It's not USH 2000 alone. Pesticide Act come into place. Environment quality regulations come into place as well. Yeah. So we need to basically understand the hazard and the risk, the routes of exposure, the resulting health effects, and the implementation of effective control measures. Yeah. A little bit into hazard versus risk. Yeah. A hazard is an intrinsic property of a chemical which can cause harm, while a risk is the likelihood that the chemical will cause harm under specific condition of use. Yeah. Meaning to say a highly toxic chemical can be low risk if handled with proper precautions, while a less toxic chemical can be high risk if handled improperly. Yeah. Dose is the amount of a chemical that enters body, and it's critical in determining the outcome of exposure. Dose is dependent upon concentration, frequency, and duration of exposure. Yeah. For harm to occur, a chemical must enter the body through some specific routes. Yeah. Inhalation will be the most common route of exposure. Yeah. Where breathing in gases, vapors, fume, gases, and aerosols, which came from the chemical hazardous to health. Yeah. Skin or eye absorption is the next route, where a direct contact most commonly causes local damage such as irritation or corrosion first, but there are times on a higher concentration of exposure, it can be absorbed into the bloodstream, affecting the target organs. Yeah. This is a little bit uncommon ingestion where swallowing of chemicals due to poor hygiene, usually, example, eating with contaminated hands. Yeah. And this is again another uncommon route where injection, where there's an entry through a break in skin, for example, after a sharp injury. Yeah. Dose response relationship is again something that we need to be aware of. Yeah. So essentially, in the bigger picture, CHRA and control measures is the most important aspect. CHRA and chemical exposure monitoring are meant to improve the existing control measures. There is a need to re-evaluate after the improved control measures are implemented. Yeah. Then we perform medical surveillance when necessary for the purpose of early detection and early intervention. Yeah. And this is again to improve the control measures which need to be improved specifically to what our findings were, and again to reevaluate. Yeah. So our job is essential in the big picture. Yeah. And there is a need to cooperate with other orang yang competent, such as the safety officers, the hygiene tech, the CHRA assessor, the chemical exposure monitoring, the hygiene tech, the safety managers at place, employers. Yeah. So it's essentially a teamwork. Yeah. Okay, so coming to the first case for today. Okay, case number one is a technician who works in a yard, in a workshop. The exposure is to welding activities, where in the CHRA documentation, it was found that the worker is significantly exposed to manganese, chromium, and nickel. Yeah. So in any welding activity, there is commonly exposure to welding fumes, manganese, chromium, and nickel. Yeah. And depending on which type of activity, which type of steel or substances which they are, using, the concentration of this can vary. Yeah. So, for example, if there is usually in stainless steel, chromium will be higher. Yeah. So it really depends on the substances. Yeah. So for this worker, the history survey was insignificant. There were no health effects. Yeah. Manganese was normal, nickel was normal. However, urine chromium was raised. Yeah. During the review of the CHRA assessment, it is found that through the adequacy of control measures through inhalation route were inadequate. Yeah. So these are the just one or two page from the CHRA document. Yeah. So welding activity, inhalation route, adequacy of control measures, inadequate. Yeah. They have documented what are the existing control measures. Yeah. But during the assessor found that the control measures are inadequate. Yeah. And the more we read the document, yeah, the more findings we can get. Yeah. If we take the time to call the assessor and talk privately, there can be things that can be picked up which are not even documented in the report. Yeah. Right. So continuation of case one. So the OHD decides that this worker is temporarily unfit for exposure to welding activities due to abnormal chromium level, notified to DOSH, issued MRP for 3 months. Why 3 months? Because there is a need to allow adequate time for improvement in the control measures. Yeah. So commonly when this happens, they need to conduct a internal investigation. Yeah. Then DOSH would visit the workplace, and that would be external investigation. Yeah. They conclude what are the findings, whether it's really related to work or not. If it's related to work, what is the issue? Is it substandard condition or substandard practice? Yeah. And those conditions need to be improved first. After improving the condition, then only it has to be again reevaluated, documented, and then only we can say that it's kind of adequate to perform a return to work. Yeah. So all this takes time. So in certain situations, if we are kind of aware that the company needs some time to improve the control measures or to perform their internal investigation, we may need to allow more time. Yeah. So the MRP for 1 month alone may not be enough. We may need to extend up to 3 months. Yeah. And the reassessment in 3 months should be with documented evidence of improvement in control measures. Yeah. So after 3 months, a return to work assessment is done for the same worker who is going to be exposed to the same activity. Yeah. Of course, even from earlier assessment, there's no health effects. Yeah. Urine chromium has normalized. Yeah. However, the adequacy of control measures is still inadequate. Yeah. So in these situations, although everything else appear to be okay, but because the control measure is not adequate yet, we cannot allow the worker to be back to exposure to the chemical which is of concern. Yeah. So there is a need to continue the MRP another 3 months because no evidence of improvement in control measures. Yeah. And reassess with documented evidence of improvement in control measures. Yeah. So what happens if there is no improvement of control measures for months and months and months? Yeah. Usually it's unlikely because usually DOSH will come into place and do what is necessary. They'll push the company to do what is necessary. Yeah. So there should be improvement by right. Yeah. For some reason, if there is no improvement, that may indicate that this MRP is going to be permanent, and the permanent MRP is something that may trigger us to investigate. How about the rest of the workers in that work unit? Aren't they exposed to the same scenario as well? The inadequate, control measures. Yeah. So in that sense, usually there would be some form of improvement in the control measures eventually. Yeah. And very rarely such simple case goes into a permanent MRP. Yeah. All right. Coming to the second case. Yeah. This is a technician working at a workshop at yard. Exposure to the same welding activities, and the concern if the same three chemicals, manganese, chromium, nickel, no health effects. Uric chromium is found to be raised. Manganese and nickel is normal. Adequacy of control measures, again, inadequate. Yeah. So, same findings from the CHRA assessment. Inadequate control measures. So, unfit for welding activities due to abnormal chromium level. Notified to DOSH, MRP for 3 months to allow adequate time for improvement. And reassess in 3 months with documented evidence. Yeah. So in this particular case, after 3 months, the biological monitoring has normalized and the control measures has improved and found to be adequate. Yeah. Not only there must be an improvement, it has to be found to be adequate. Yeah. So in this scenario, we can allow the worker to return to work. Yeah. The next surveillance can be 1 year if all goes well. However, for some reason, if you have any doubt whether if there is any possibility of recurrence due to some form of substandard condition or substandard practice, which is still you are not so happy with, you can always recommend to reassess within 3 to 6 months. Yeah. All right. This is the next case. A technician working in a workshop in plant. Exposure to welding activities. Similar chemicals of concern, manganese, chromium, nickel. He has a history of non-Hodgkin lymphoma, completed chemotherapy, and now is under remission. Yeah. Yes, there are health effects, but none are related to work. Yeah. The biological monitoring are normal. Control measures are inadequate. Yeah. So here's a scenario that the worker is unfit for welding activities due to being exposed to carcinogenic chemical hazardous to health. Yeah. A person with existing cancer will have is a susceptible individual. Yeah. where a susceptible individual is more prone to develop secondary problems, or other health effects when being exposed to chemical hazards to health, and in this individual, the rules which are applied to a normal individual does not work, does not apply that way, it's not similar. So there are additional considerations that we have to take for this particular worker, So the decision was this particular worker is permanently unfit to be exposed to those carcinogenic chemical hazards to health, Since this matter is not related to occupation, hence there is no need to notify to DOSH. But there is a need to notify via use 51 form, to the employer, So if you are posed a question that if the control measures are improved and found to be adequate, can the employee return to the working activities, In this particular scenario, it is still not recommended. As I explained earlier, this is a susceptible individual and potentially detrimental to the health of this individual, even at low doses, So we must understand that the control measures is not going to eliminate the chemicals up to zero, There is some level of the chemicals going to be present all the time, It might be at lower levels, But it's not going to be zero, And for a susceptible individual, this individual, even at low doses, can develop health problems, There's increased risk of secondary cancer or other serious health issues, Okay, you may even be posed a question, can this employee now get transferred to other department or work activities which is exposed to chemical hazards to health, but it is not carcinogenic, So they are basically asking you if I transfer him to a different work unit where the chemical isn't as as significant or severe as the one that he was exposed before, So there's no hard and fast rule in this, There is a need to have careful consideration where there is a need to have a consultation, an in-depth conversation with the oncology team or primary care physician. They can be referred back, can be to the physician to assess the patient's immune function, potential long-term side effects, and overall risk to whatever work activity which is being suggested, The specific hazard must be identified. While some chemicals are general irritants, others are generally carcinogenic or immunosuppressants, A thorough risk assessment should be conducted, and this risk assessment is no longer a general risk assessment, it is specially done for this particular individual, So in the meantime, the employer may be able to provide a reasonable accommodation not involving chemical hazards to help the employee to perform job safely, So if the employee is no longer involved to chemical hazards to health, of course the safety factor is much better, All right. Coming to case number 4, a technician working in a workshop in a plant, exposure during maintenance activities is towards silica, The history is insignificant. There were health effects found where from the lung function test, this worker has severe restrictive lung function, and furthermore, this is suspected due to the presence of severe thoracic scoliosis,
one of the commonest side complication of severe thoracic scoliosis would include restrictive lung disease. Yeah, right. So when the overall findings, from the overall findings, the OHD is able to determine that this finding is unlikely to be caused by silica. Yeah. However, there is something that the OHD needs to do. Yeah. Okay. By the way, the control measures were inadequate. Yeah. So the control measures were inadequate. Yeah. So right now, there is a need to refer to specialists for further evaluation and management. Yeah. Mainly to determine that is your suspicion correct or not. So if we are suspecting that this restrictive lung disease is due to the presence of, is due to complications of the thoracic scoliosis, we need to confirm it. Yeah. Whether is this the case or is it due to something else. Yeah. And this worker would be temporarily unfit to use respirators due to severe restrictive lung function. Yeah. Issue a temporary MRP. Yeah. And the reason for MRP is because it is mandatory to use certain types of respirators when you're exposed to silica. Yeah. So without any respiratory protection, you cannot impose the worker to be exposed to silica. Another determination is, of course, in the long term, you suspect that this worker may not be suitable, or it may be unsafe for this worker based on the lung function to use a respirator in the workplace. Yeah, because the lung functions are poor and the usage of the respirator may not be suitable for this particular worker. It may cause more harm. Yeah. But at this moment, you do not know conclusively because you don't have the specialist evaluation done yet. You don't have the specialist reports yet. You haven't discussed with the specialist yet what is the exact findings, what is the cause, yeah, and what is the way forward. And in some scenario, the problem can be corrected. Yeah. So say if the primary problem can be corrected, we need to determine in the future, can the respiratory restrictions get corrected by itself or not? Yeah, is it a temporary problem if the primary problem is corrected, or is it going to be permanent? Yeah. And since we don't suspect this due to workplace exposure, we don't need to notify to DOSH at this moment. Yeah. But everything else has to be done. Yeah. All right. So that would conclude the cases for today. That also concludes my sharing. Yeah. All right. So I guess now it's time to open for Q&A. Yeah. All right.
Okay. Doctor, would you like me to read for you or you want to read yourself from the Q&A box?
Okay, let's see. Yeah. Okay. How do we determine relatedness for non-specific symptoms? Yeah. Whether it's due to medical cause or chemicals. So these are from the symptoms itself. We have to see what is the probability. In the medical line, we look at probability rather than possibilities. Yeah. So headache, dizziness, insomnia are almost invariably not due to chemicals. So of course, if this is persistent, you can always refer to a physician to determine what is the exact diagnosis. And if the diagnosis is not related to work, you maintain that it is not related to work. For some reason, if it's related to work, then that's where the OHD's role comes. But looking at the symptoms, these are unlikely related to chemicals. Yeah, if at all, it's related to work. It can be due to fatigue at workplace or stress at workplace and so on. Yeah. So this very non-specific symptom doesn't seem to be related to work at all. Yeah. Okay. The next question: where to download the form? Well, we go to the DOSH website, and we look for the part where the you know guidelines for the medical surveillance. Download the guideline for the medical surveillance. Let me try to share if I have it here. 1 second, I'll try to look for it. Okay, can you see this guideline? Sorry, this is not it. Sorry. Okay, so this is the one. So we should be able to download this guideline. All right. So this is like a huge journal by itself, more than 500 pages. So if we are to go to the contents, we will get very nice guidelines on everything that we need. Of course, some of it we will have to refer to the Surah Arahan from time to time, where they may have issued some changes on biomarkers or some of the standards applied, yeah, to the guideline. Then, Appendix 7, yeah, Appendix 7, MS recommended forms will be the forms that we are going to use, yeah. So, say if we go to page 523, not yet. Further down, as you go further down, you'll find the forms eventually, yeah. Right? So, use 1, use 2, use 1, use 2, use 3, 4, 5.1, 5.2, yeah, so it's there. Right, so those who don't have it yet, just go to the DOSH website and just download, yeah, right. Okay, the next question: how does the OHD determine the adequacy of control measures after the MRP? So this is where there should be a documented evidence, yeah. In the initial period, you may only get the documented report of, say, the internal investigation conducted by the company. You may get the report of a DOSH visit to the workplace, and then on subsequent DOSH visit, they might document what was the rectification or the improvement done, or the safety officer or the HSE manager may provide you a report to say that this was the problem and we have corrected by this. Yeah. So that would be enough eventually. Yeah. Subsequently, once this officially the control measures have been rectified, there is a need to update the CHRA document by the assessor, yeah, preferably by the same assessor. So the same assessor who determined that the control measures previously were not adequate. Now, when things are improved, the same assessor is now determining whether this is now adequate or not. That should be the most official way, yeah. But in the initial period, the internal reports and the DOSH audit reports would be sufficient because you need to decide within 1 to 3 months, and that's the only document that you can get within that time. To update the CHRA and all that, that's going to take a longer time. But eventually, there is something that needs to be done. Yeah. Hope that answers the question. Yeah. Right. So, how do we determine the duration of MRP? Yeah. Must it be 3 months? No. It all depends on case by case basis. Yeah. The examples which I gave is 3 months because the OHG is already aware the adequacy of control is not there. Yeah. One of the example which I provided, and if you go through the guidelines, you get more examples. Yeah. For example, lead is high, and within 1 month, there will be significant reduction of lead. So, in a perfect scenario, 1 month is adequate to determine as duration of MRP. Yeah. In a not so perfect world, you may need to allow more time, and sometimes this more time is just to find out what's going on. Yeah. All right. So to find out what is going on, we will need workplace investigation to be conducted. Yeah. Even if the employer is not doing any form of investigation, the moment you issue an MRP and notify to DOSH would usually move in very quickly. Yeah. And they are going to get something done. Yeah. And whenever DOSH visit the workplace, there's going to be something audited and documented. Yeah. Right. So to determine the duration of MRP, it all depends on case by case scenario, depending on the case. Yeah. Hope that answers the question. Yeah. Okay. What's the next question? Encountered a case of contact irritant dermatitis in a welder, specifically against manganese. All the biological monitor of urine, manganese, and lung function are normal. Only that the form of examination I found skin dermal findings. For this case, do we need to MRP and report to DOSH as well? Yeah. Okay. So if you are of the opinion that this is definitely due to the exposure, yeah, to the said chemical, you can impose MRP and notify to DOSH. Yeah. If for some reason this is not related to the workplace, then it's not notifiable. Yeah. But you have to decide, is the exposure going to aggravate a non-occupational disease? Yeah. And what can be done for it? Yeah. So, and also the question would arise, how confident are we that this is a contact irritant dermatitis? Yeah. Where is the proof? What is the data to support us that this is definitely contact irritant dermatitis and not other issues where not related to exposure at home, for example, yeah, due to dust mites or things like that, yeah. So that's where a lot of history correlation and examination comes into place, yeah. But yes, the moment you suspect that, it's almost definitely suspected due to the workplace, you can notify and allow the investigations to happen. For suspected cases, you need eventually to get the reports of the investigations for you to determine if what you suspect is definitive or not. Yeah. And most often than not, it's time to turun padang. Yeah. So as mentioned, the workplace investigation is not confined to the company or DOSH alone. Yeah. We may need to go along during the time when the investigation is being done, so that we get better understanding of what is happening. So that we can determine whether what we suspected is definite or not. Yeah. I hope that answers the question. Yeah. Right. Okay.
Okay. Participant, is there any other questions to Dr. Ruben before we proceed to the quiz session? Okay. Thank you, Dr. Ruben. Macam tak ada soalan lagi, I think.
Any other questions?
Participant, kalau ada berapa soalan?
No. All right.
Okay, we proceed with the quiz session, ya, Doctor? Okay.
All right. So thank you for inviting me. Thank you, Zara, and thank you. Hope the session was helpful to all the participants. Yeah, and hope you enjoyed the next session after this, which will be from one of my favorite speakers, Dr. Lim. Yeah. Right. Okay. Thank you. See you next time.
Thank you, Dr. Ruben. Okay. So, Aisha? Okay, so you guys already know the rules for quiz sessions, and you also know the gift that we're going to provide you. So only one winner, yeah, for per quiz, and then okay, don't you can scan the code on your screens, and don't forget to enter the code 25204995, or you can click the link given in the chat box to join the quiz sessions. So you have 1 minute from now to join the quiz. Okay. Hera. Okay, congratulations goes to Nur Adila. Okay, don't forget to WhatsApp us your address and your full name so that we can post the gift to you. Okay, everyone. So it's look like we are at the lunchtime now. So participant boleh pergi lunch dulu.